This is Herb Kressel, and welcome to the Radiology Podcast. Today I'm joined by Dr. Matthew Davenport from the Department of Radiology and the Departments of Urology at the University of Michigan Health System. Dr. Davenport and his colleagues authored a provocative study entitled 5-Hour Intravenous Corticosteroid Premedication has a breakthrough reaction rate that is non-inferior to that of the traditional 13-hour oral regimen. Welcome, Dr. Davenport.
Thanks for having me.
Yes, and I should note all of your many titles. You're the Associate Chair of Quality, and it sounds like this is relevant to that duty. You're the Director of Body Imaging and Associate Professor of Radiology and Urology. And in addition to those heady titles, you currently chair the ACR Committee on Drugs and Contrast Media. I couldn't think of a better person to discuss this manuscript. So welcome.
Thank you for having me.
Sure. Now, what are the current ACR recommendations regarding pretreatment with corticosteroids for those patients who are at risk for allergic type reactions and who are scheduled for contrast-enhanced CT exams?
So we are currently in version 10.3 of the manual. At the time that this paper was done, we were in version 10.2. And the reason why that's relevant is because between those two editions, the guidelines actually changed a little bit. So our current guidelines are for patients at risk, which is defined as a patient who's had a prior allergic type reaction to contrast media of the same class, meaning they previously had a reaction to NSAID contrast, they're now getting NSAID contrast again, general class. Then steroid premedication would be indicated for that patient. And traditionally, it is given over a 12 or 13-hour period in an oral format. And people have tried using faster IV regimens just because logistics have demanded it, but to date, there really wasn't any significant studies to justify that behavior.
Okay, and can you just kind of review sort of what is the underlying evidence base that this actually is a reasonable approach to these high-risk patients?
The best evidence we have are from two randomized trials by Lasser et al., and they did two of them. One was in 1987 studying high osmolality contrast media that we don't use anymore for intravenous administration. And they tested average risk patients, which means just the general population getting contrast, and giving steroids prevented reactions of all severities. So that seemed like a pretty good thing. Then in 1994, they repeated the same study design, but due to monetary reasons or logistics or whatever, they were underpowered to talk about moderate and severe reactions. So although, again, they tested average risk patients, they showed a reduction in aggregate reaction rates and mild reaction rates. They were unable to show differences in moderate and severe reaction rates. And some people criticize the evidence base for that reason because we don't have proof that giving a high-risk patient steroids works, and we don't have proof that giving average risk patients modern contrast media reduces the risk of moderate or severe reactions. Most experts, not all, believe that there probably is an effect, and it's not the question of whether it works, it's a question of effect size. How many preps do you need to give so that somebody doesn't die? Sure.
So what is, now you focused on the specific issue of the 5-hour oral prep. So why did you decide to do that study?
So traditionally we had a 12 or a 13-hour oral prep, and what we compared it to was a 5-hour IV prep. So a different mode of administration and over a shorter time period. And the rationale for that is there was a case series of like 9 subjects from the 1980s that tested something like this and found they didn't have any reactions observed in that tiny cohort. And based on that very tiny shred of evidence, the ACR has stuck this regimen in its contrast manual for a long time. And we were curious to know whether it actually worked.
Right. Sounds like a good idea. So this is actually, as you've mentioned, a non-inferiority study. Can you explain the study design for viewers and listeners who may not be familiar with this term? What is the design and when is it appropriate?
So the average hypothesis-driven study that someone would do uses what's considered superiority assumptions for their power calculation. I want to know whether X is better than Y. And sometimes we end up with a negative result in those cases. But then we don't have a lot of confidence that the negative result means anything. That's what leads to all this publication bias where only significant results get published and non-significant results don't. So you don't have too much confidence that the negative result means something. We power a study using non-inferiority assumptions or equivalence, which is even a higher standard. You're trying to say up front, I believe that regimen A is non-inferior or at least as good as regimen B, and you assign the power appropriately. And when you do that, you say, what risk threshold am I willing to tolerate? And in this case, we knew that the breakthrough reaction rate was somewhere in the 2 to 3% range for the 13-hour oral prep. And we said, how much are we willing to tolerate if this risk for this other regimen, this 5-hour IV regimen, is higher? And we said, well, about maybe 4 percentage points. So we don't want to go higher than 6%. We think 6% will be within a clinically acceptable range of breakthrough reactions. So then we set our confidence intervals up front and say how much width on our confidence we're willing to tolerate, and we power it appropriately. So non-inferiority design goes into it saying regimen A is not worse than regimen B. It's like a one-tailed test.
So in a lot of the non-inferiority designs, we've seen the margin, the non-inferiority margin, is drawn from prior literature or something that gives you confidence. And yet you did it based on sort of clinical intuition, it sounds like, that if it was beyond this, we would really worry that it really, we wouldn't want to use it. So it was just clinical judgment.
Yeah, I think when you choose a non-inferiority margin, the clinical judgment is actually more critical probably than what the literature says, because you want to know what are you willing to tolerate. If this actually is worse than regimen A, how much risk can you tolerate from a clinical standpoint?
Sure. Now, you used a statistical test that I wasn't familiar with, the Farrington and Manning non-inferiority likelihood score for your figure of merit to assess non-inferiority. Can you tell people viewing and listening what this is? They may also not have been familiar with it.
So I am not a statistician, so I'll get that right out front. But basically, it's a way of doing non-inferiority tests, comparing two proportions, where you look for the difference in the rates. So let's say rate A is 4% and rate B is 2%, and then you establish up front an expected confidence interval on the difference between the eventual rates. And then you set the threshold appropriately. So in this case, the upper bound on our threshold was 4%.
So it's appropriate when what's being compared is a percent rather than an absolute number.
Mm-hmm.
Good. Okay. So now we understand all of that. What did you actually find in your study?
So essentially, we found that if you give patients who are at risk, meaning they've had a prior allergic type or unknown type reaction to identity contrast media, and you give them pre-medication with a 13-hour oral regimen, or you give them pre-medication with a 5-hour IV regimen, their rates are statistically indistinguishable. In other words, the 5-hour IV rate is non-inferior from the 13-hour oral rate, which, if true, is important because it really would change how patients get pre-medication in the inpatient and ED arenas where they already have an IV, they're already a captive patient population, and it's not additional challenge to give this kind of prep to them. And it can dramatically speed up how much time it takes for them to get their scan.
Good. So going back to the power issue, was your study adequately powered to support this conclusion?
I would say yes. When you have a non-inferiority study design, you establish what your difference is that you're willing to tolerate, and assuming that your difference ends up being within that confidence, then you say, yes, I have confidence in the conclusion. That's the whole nature of doing a non-inferiority design.
Sure.
Power it that way.
So getting back down to things at your institution, have your findings altered the approach to these patients at your own institution?
Yes. It's affected two things, actually. On a national level, now the ACR manual version 10.3 has changed its recommendations for how steroid preps are given, in part because of this article. And now what it says is if you are a patient in which delay caused by premedication would adversely affect care decisions, which basically is all the time when you're an inpatient or ED patient, you really should be using this 5-hour IV regimen when it's indicated as opposed to a 13-hour oral regimen. And simultaneously with that, we also changed our local practice. So essentially, we don't use a 13-hour oral regimen in the inpatient ED arena at all. If someone comes from 4 hours away and they would have been indicated for a prep, we sometimes would use the 5-hour regimen on that patient also. So yes, it's changed.
And I imagine it's been well received at the Institute.
Oh yes, yeah, they were rolling out the confetti, I'm pretty sure.
Very good. Well, this is a very practically useful, important bit of information, and I thank you for the paper. It was very well done, and I think very important work, and it's been a pleasure speaking with you about it.
Likewise, thank you.
Thank you. Take care.
Thanks.